Good afternoon. Thank you so much. It's a privilege to be here, and thanks to the panel. Penny Anderson tells me that it's Macrum's birthday today, so happy birthday. That's dedication. So I have the privilege of working with Paul. He kind of gave me a tough title, a new imaging method I found in the last year. So to keep it relevant to this context, I took the liberty of changing it slightly to a new old imaging method I found in the last year-ish. Here's my disclosure. So this is the interventional echocardiographer pain scale. Yes, your echo folks do have feelings, and we do feel pain. So, TAVR's down in the greenish range. MitraClip before 3D, before we knew what we were doing, was kind of in the orangish, but now it's down in the green. But when it comes to tricuspid valve clipping, I have to admit in the first several cases, we're really pushing into the red zone. And this kind of illustrates how I felt with our first tricuspid case. I'm struggling with this IE33, and I'm not getting great images, and everyone's getting frustrated. So what was my problem? Well, I was treating it exactly like MitraClip, and it's not the same. With MitraClip, 3D's really changed everything. You get a nice assessment of anatomy, what's going on. Here we see there's a A2 and a P2 flail, and you have scissor-like jets coming across, and you can see that very quickly. Clip arm alignment and assessing for rotation. When you go into the ventricle, very easy with 3D. You get nice views of leaflet insertion as well. But when you try to go to the tricuspid valve, 3D is not as good. And every once in a while you get some nice images, but you get these moth-eaten leaflet appearances, and sometimes you get images like the bottom. It's kind of like a nuclear study. I'm just kidding. But so what's the problem? Well, the tricuspid valve is not the mitral valve. You have very thin leaflets. You get dropout with 3D. You can see you can get shadowing from the lipomatous atrial septum. If you have an AVR, that'll get in the way. The insonation angle is not ideal for 3D. You like the valve to be perpendicular to the scan line, and the tricuspid valve tends to be tilted. And from the esophageal views, you're in the far field. So what's a poor interventional echocardiographer to do? And what I should have listened to Becky earlier, the key is you got to go back to the future. So back in the old days of MitraClip, before we had 3D, I don't know if any of you remember, we had to struggle with this transgastric 3D of the mitral valve. And it wasn't easy to get, but if you could get it, you could really see leaflet insertion, clip arm alignment. And that holds true with the tricuspid valve. Here you can see this transgastric short axis view of the tricuspid valve. This has been really instrumental to TriClip procedures. You can see the leaflet anatomy quite well with a lot of detail. You can see where the regurgitation is coming from. But this isn't an easy view to get. You have to have a little patience. So it tends to be a more shallow transgastric view. You got to play with how much flexion you have on the probe, and then you have to play with the angle to get all three leaflets in view. So it's kind of using the force a little bit, but it takes some practice. But when you can get it, this really is key for tricuspid valve clipping. So that, and also this short axis view at the esophageal position at the base. This is analogous to, with MitraClip, you get the commissural view on the left and your grasping view on the right. Here you can see the 3D images on this patient aren't that bad. You get a general sense of where the tricuspid regurgitation is coming from. But you can see on the transgastric views, let me try that again. This is a quadricuspid leaflet, and you wouldn't be able to really pick that up on the 3D views. Sorry. So similarly, when you have clip arm alignment, when you're in the RV, you can try to use 3D. It's a little less helpful, but you can see if you can get a nice transgastric short axis view, you can really see where the clip is along the commissure and the clip arm alignment relative to the commissure. And that really sets you up for a good grasp, an effective grasp. After the clip is closed, The same view, you can really see leaflet insertion well, a nice tissue bridge. You can see if there's residual tricuspid regurgitation here, there's some anterior to the clip. And you can see that on 3D as well, but just not with as much spatial resolution. So based on that, we put another clip in, just anterior to the first clip. One problem with this view is if you put another clip anterior to the first clip, you'll get some acoustic shadowing from the first clip. But here we have a nice result. Here's another example where we have a coronary sinus lead, and the 3D is helpful because it tells us that the regurgitation is mostly anterior to that coronary sinus lead, so we probably have a good shot of getting at the tricuspid regurgitation without being affected by the lead. But here again, from the transgastric short axis view, you pick up that there's this cleft in the anterior leaflet that you might not have seen from the 3D, and that the regurgitation is kind of around that area of cleft and going more posteriorly. So based on that, we direct our therapy, we get the clip into the RV, and because of the shadowing with multiple clips, we decide to put this first one more anteriorly. We push it a little bit forward, and we just want to be on just the anterior side of that cleft. And here you can see, again, with this short axis view, that we have a nice tissue bridge just anterior to the cleft. And the residual tricuspid regurgitation is just posterior to that. And then we put our second clip in, and you can get a nice view of the clip arm alignment, just posterior to that first clip. And then as we close, we get a nice tissue bridge. So it gives you a lot of confidence, gives you a lot of detail as to where to go and how your clip arms are aligned. And here, again, we have a nice result. In that same patient, the 3D, you can see the two clips, just not with the same spatial resolution. And I really think that that transgastric short axis view is really key for tricuspid clipping, and it's something you need to practice. So here we had a mean gradient of 3, nice clip arm clip alignment, parallel to each other. So in summary, 3D imaging of the tricuspid valve can be challenging with suboptimal spatial resolution, and transgastric imaging in the short axis view can yield more detailed information about anatomy, pathology, location, clip arm orientation, and leaflet insertion. So you need to practice this view. The interventionalists also need to be familiar with this view, and it'll pay dividends with interventions down the road. And if you do enough of these, you start really thinking about tricuspid anatomy. You have the bicuspid, tricuspid valves, trileaflet, quadrileaflet, but this is actually a picture of Neanderthal teeth. You start seeing tricuspid valves everywhere. Thank you.